Okay, we're going to get started. Hi, everyone. I'm Beth Bernabeo. I am facilitating this discussion today, along with Rick and Nancy and Kathy. Thanks for being here. I am a research associate at the American Board of Internal Medicine, so I'm very fortunate to be part of such a intriguing discussion today. So with that, so far at today's workshop, we've talked about and discussed professionalism as a contract developed with society. And for our purposes, society in the narrowest sense involves patients and communities, and in the broadest sense, society engages all patients, persons, and communities around the world. We've discussed the possibility of bringing our different professions together in this area of professionalism for developing a social contract. And what we want to do today in our breakout group is to try to come to a shared understanding of the elements that may make up this shared or transdisciplinary contract. And to do this, we're going to spend about a little less than half our time, so roughly until about 2:05, talking about case studies, unique case studies that the group has come up with that are meant to stimulate conversation and thinking. They are not intended to produce one response or possibly even a finite number of responses. And in fact, we may see that the case studies generate more questions than they do answers. And we're all okay with this. This is designed to be that kind of discussion, an inductive, just kind of brainstorming discussion. So the format of this workshop is as follows. Each of the small 4 groups that are going on at this moment, we will all be using case studies to generate these kinds of discussions. And following that, we will all be using the same 3 slides to populate different perspectives from our group. And the purpose of this is then when we reconvene in our larger groups later, we hope that there are some commonalities among these 4 groups. We've used all the same slides. We've had similar kinds of discussions, although from different perspectives. And we're hoping to see, again, if we can identify some commonalities and themes among the professions. So with that, we will get started. We're going to start with our case study 2, which focuses on accountability and leadership. And I'll read it to you out loud, and then we can begin our conversation. You are a member of a well-functioning surgical team that works together as one unit. There is shared leadership, so the entire quote-unquote team receives credit for the team's successes, and no one individual receives outstanding recognition. However, the last surgical procedure went terribly wrong. As is their custom, the quote-unquote team took full responsibility for the unanticipated negative outcomes. So what we're charged with talking about today is whether or not one person on the team can ultimately be held responsible for the unanticipated negative outcomes, as well as how this team-based approach to shared responsibility resonates with a number of stakeholders, including insurance companies, lawyers, hospital administrators, and other members of the team.
Could I ask if I'm the only surgeon in the room? It's a serious question, actually. Any other surgeons?
No, but we have a nurse anesthetist in the room.
Okay.
As an ex-hospital administrator, I have to say that when something goes wrong, it is never a person's fault, but somebody has to take somebody has to be responsible, and usually that is the team's decision of who is the leader, and that's decided before you start pointing fingers at each other. What we did with things that went wrong is that we got everybody together, found out what in the system had made it happen, and see if we could change it so it didn't happen again. And this was done confidentially. And we're not as litigious as our neighbors down here. So that the lawyers accepted the fact that they couldn't have access to deliberations. It's just sort of to put it in perspective, is that when something goes wrong, it is never a person. I'm not sure how the team taking full responsibility would actually work out with lawyers and members, you know.
Okay, yep.
So I sit on the board of a healthcare organization, and in particular, I sit on their quality of care committee. And one of the things that we would do as a board and as a quality of care committee is we want to understand what the causal chain was, the root cause, and we would do a root cause analysis to get to exactly what it was that happened. The purpose is not to blame an individual or not, but the purpose is to understand what was it in the system that failed, however it was organized or set up, so that we can do a continuous quality improvement on it. So the orientation is not for purposes of blaming this person or that person. It's because most of the time something set a series of failures going, or things that didn't happen as they should have happened. What was that, and how can you prevent that from happening again? So I think from that standpoint, I want to point out that it's not just the surgical team that's involved here, but it's also the board team and the executive team and the other levels within a hospital that are responsible for this.
I just sort of raise a little contrasting view just because I need to be educated. As I look at cases, it's not a dichotomous variable. And that for moving forward, there's a lot of systems drive a lot of quality and safety, but there's also an individual agency. And you have a separate choice of what's the right way to bring that forward and how to remediate it and whatnot. But I don't know whether it's 20% individual and 60, 80% system, but I've been in our setting saying, well, it's mostly systems and it's mostly non-blaming and whatnot, but there really are some people who are, you know, the old QA bad apples that you want to make sure are intervened on. And so while it isn't a dichotomous variable of moving forward, it seems to me.
Okay. I think Richard.
Yeah, you got to remember I'm really old. But, and I'm not arguing with the premise and the issues we're talking about. I'm arguing it with this particular scenario, which in no way corresponds with my life as a surgeon. Give you two instances. We always had a well-functioning team and all those good things. I cut a femoral nerve doing a total hip one day. My responsibility, nobody else's. Wrong for anybody else to take responsibility. I had a patient die on the table, anesthetic death. I was happily bashing away as orthopedic surgeons do, and the patient had an anesthetic crisis and died. I, of course, had to talk to the family, but that anesthetist at fault needed to be accountable, needed to be. So my world just doesn't correspond with the way this is phrased. It isn't that I'm disputing the necessity for team responsibility. And I would also talk, again, I'm going to talk in surgical terms, but this is also true in other things. We talked about downstream events that alter what we're trying to do in institutions. If I was probably going to get sued equally with the anesthetist, and I was certainly, I wasn't in either instance, by the way. It was in Canada, where suits are not, they're not unusual, but the incidence is much lower. You know, that you have to look at liability and so forth and so on. And team liability, to my knowledge, has not yet been established in the courts, and it influences what we're trying to do downstream. And again, I'm not arguing against what we're trying to do. What we're trying to do is admirable.
How about you?
You, okay.
And if anybody wants to respond to that, I'd be delighted, but.
Okay.
No, actually, I agree with you completely. In reading this, I thought you were actually going to go where I was, which I'm having trouble suspending disbelief, if you will, with the term team. Because although I practice currently in a very high-functioning cardiac anesthetic team, the way that that team defines itself and interacts with itself on a daily basis is different on Monday than it is on Tuesday,
Absolutely.
is different on Wednesday. And we are a highly functioning team that is absolutely perfect when everything goes right. The problem is that when things don't always go right, and sometimes we can anticipate them and sometimes we cannot, we define ourselves as a team differently than we would if that hadn't happened. And the idea of team and full responsibility as it pertains to actual clinical practice versus some of the more conceptual notions that we've discussed today, I think are two very different things. And finding a way for them to, whether it's upstream, downstream, the students taking the lead or the educators taking the lead, we have to find some kind of common ground in the middle there so that team always means the same thing.
Hi, I'm Darla Spence-Coffey, and I'm from the Council on Social Work Education. So I've never been in the operating room except as a patient, and I'm glad of that. But this case study really begs the question around the difference between shared responsibility and diffused responsibility, because I don't know how a team takes responsibility. I do think that there is what the process afterwards, the discussion and so forth, but I do feel like it is about owning your piece, and it might be most of it, it might be a small part of it, but really thinking through what occurred. If the team takes responsibility, I don't know how the team, as a diffuse concept here, learns from that mistake. And that's, there's tremendous value in mistakes if we take the time to learn from it. So I think that that's also something that's just really important here.
I'm David Marsh from the Northern Ontario School of Medicine. I am a physician, but not a surgeon, but I have been in the operating room. And I'd like to say a couple of things about this. First, I don't think in any situation people hold an entire team equally accountable, because different members of the team have different roles and different accountabilities for their piece. And you can ask the manager of the Dallas Stars that this morning, or Alex Ovechkin. Maybe he didn't score enough goals last night. But another thing is that physicians and surgeons have much more autonomy than other health professionals. And there may be systems ways of helping to minimize bad patient outcomes if physicians were willing to accept that. A helpful comparison is with airline pilots who have to do hours of simulation on a new type of plane before they can fly with people's lives in their hands. Surgeons aren't required to do hours of simulation on a new procedure. They learn by doing it often.
Sometimes they are, actually.
They don't.
It's coming.
They don't today have to blow in a breathalyzer every time before they go in the operating room, or have limits on how many hours in a week they can operate, things like that. All of which reasonably could be expected to reduce the chance of errors.
Yeah.
Hi, I'm Susan McDaniel. I'm a psychologist at the University of Rochester, and I have been in the operating room, but not with the knife. And I think, there are mistakes. This is such a global statement. Sometimes the mistakes are in the communication, and then I think it is, a team responsibility in a sense. Sometimes, the surgeon makes a mistake, and it's clearly that person's, and how you create a system that is centered on what the specific patient and the problem is, and that everybody's willing, as you said, to look at their part. It's not some diffuse, we as a team are taking responsibility. It's much more, but it's also not just the individual looking at what were the communication patterns, what were the systems issues, and was there either a mistake or somebody was ignorant,
I think that
what this little case does, though, is sort of bring up all the elements of the things that we've been talking about this morning, and sort of creating the team. Here is where the rubber hits the road. So what does, as we talk, what does autonomy really represent on a team? How much does responsibility and success go to individuals within there? The issues around the structure of the individuals within the team, and are teams going to be different across the board? Obviously, either in the OR, on the ward, in an ambulatory setting, or in a community setting. So while we may take some exception to some of the pieces of this, I think it does really bring the elements of what it is that we're talking about, and what is it going to mean as we move forward, as we start to think about the structure of it.
Mm-hmm. Sure.
I'm just interested, I'm really glad that you spoke up as a surgeon, and we have this case study up. Because in many ways, as Rick said, we're in this process of transcending or transitioning into new ideas about how we can operate in the healthcare system to make it more effective, efficient, safe, timely, patient-centered, et cetera. And so, the idea of a team being led by the surgeon, is that an old idea? Is that an idea that needs to be changed? In your experience, what are the positives and negatives of going from, and it's been, the accountability's been isolated to the physician for sure. But what if we had a system where that weren't so, that if you have a team and you assigned accountability to the team, how might that play out?
I think the reality is that patients go to surgeons. They don't go to teams. Now, patient education may change that. These things aren't immutable. But at the current time, you are referred to a surgeon, and you generally go to a person with skill. I find it almost impossible to envision an operating room where one person is holding the knife, and that person is not the person who has to lead the team. There are a whole bunch of other team sports in medicine, including critical care and lots of chronic care situations. Chronic care, there are lots of times when I think it's inappropriate for the physician to be the team leader. I think we've shown that a jillion times. So that's why I said I objected to this particular scenario. You don't want to be operated on in a situation where the surgeon is not the team leader. I promise you. Now, if there are anesthetic complications, the leadership shifts and the surgeon stands aside, and every single surgeon has had times when in the operating room they put a moist sponge, they cover up the wound, and they wait until their patient either survives or doesn't, something to do with other conditions. So I think when we're talking about teams, we have to be really, really careful and look at the context. And frankly, I think that interprofessional education, transprofessional education is also subject to that type of situations. We've got to teach teamwork in situations where teamwork really works. Now, there are lots of instances in operating rooms. I mean, checklists is a team sport too, and checklists have transformed operating rooms and made them much safer for patients and for other healthcare professionals. So it isn't that it's a different type of teamwork. So
Well, I
I've
think
talked too much.
also, we're talking maybe more very, very specifically when we say inside the operating room with a surgeon and a team. I know many surgeons now are going towards a team effort to take care of hip surgeries, for instance. So it involves, like maternity, you go in to see the doctor and you want this done, and then it follows you through inpatient, outpatient, and wraps around all of your needs as you move through that process. So in that sense, that's another circumstance where we could see this in a different way.
I did the first total hip in Montreal in 1967, and we had physiotherapists involved preoperatively the whole time, and they were hugely important. But I set the parameters. For example, if you use a posterior hip approach to a hip, the primary instability is posterior, so there are certain motions you can't go through. So it was me who said that, but within that, the physiotherapist then advised me as to how quickly the patient could progress. So it's absolutely teamwork, but again, because of the nature of what we did, you have to be careful have to be careful you don't do harm, actually.
But what this shows maybe in a way is, the case study shows in a way is the differences of various teams. And so the ICU team, which is on three or more shifts with many different people being involved, and yet the issue of alarms keeps coming up, and ignoring alarms, and then the consequences of that, and how, as here as one of those unanticipated negative outcomes that has resulted in great harm to some patients.
Thank you. It's a very interesting discussion. I'm a family physician, but I absolutely agree with my surgeon colleague. And I'm a bit confused. We have to be a team. If I can just take an analogy, a team in the management of a faculty. We're working as a team, but the dean is ultimately responsible for something. And then I'm thinking about the military now. I don't know if operating theater sometimes looks to me like a battleground. Somebody there has got to make the orders and someone's got to follow. Fitz actually said yesterday, we must talk a little bit more about followers than leaders. We work as a team, but somebody must somewhere kind of, what is it, make the final decision. So I don't think it's opposing concepts. That's my contribution.
So I have to respectfully disagree with you in that I don't think, in my limited view of where I practice, which is a very finite place, I don't think that it is necessarily the surgeon that is the captain of the ship. I don't think in the OR the physician has to be the captain of the ship. I don't think in the critical care unit the nurse practitioner has to be the captain of the ship. I think in each entity within each team, the person that usually leads is the person that's identified as the strongest and probably the most capable to help the patient when those moments go bad. So we may have a sense of team that we are all equally responsible, and the surgeon says, I want this approach, can you give me a spinal instead of a general anesthetic? Fine, not a problem. Unless there's a situation where I say this patient is critically ill, a general anesthetic is not safe, I won't be able to extubate them, I think we have to do a spinal. At that point, then the anesthesia provider may help the surgeon identify a safe way to do that. In that situation, then I think then maybe the anesthesiologist or the nurse anesthetist would become the leader in that situation. So I think you're absolutely right. In some instances, the surgeon may absolutely be the one that is calling all of the shots and kind of leading the team and ultimately responsible. In other situations, and whether it be in the operating room or the intensive care unit or in the maternity ward or wherever it may be, I think we have to redefine from a particular role to a knowledge base and expertise to allow that person to lead.
I respectfully totally agree.
Yeah, go ahead.
The other thing that's come up the last time I apologize. The other thing that has come up for me, both when we got together the last time as well as today, is how teams vary so much in terms of time course. A lot of work with transforming outpatient practices would argue that teams reform patient by patient 20 or 30 times during a day, according to whatever that patient needs. And it's quite different than an intensive care unit where you've you've got a patient on a vent for taking care of 3 shifts of people from all different professions taking care of them. And where do micro teams fit in versus the next level of organization teams? And there's an interplay between all these different team structures. You got to be very careful about how you keep track of all those various teams, teamlets, super teams, and Uber teams, or whatever.
Oh, yeah.
It really is context dependent. I mean, who is the leader at the time is the context of what's going on. And certainly in our reviews of disastrous events, it was that somebody who didn't use their expertise at the right time, or something happened where they couldn't cope with whatever happened. But it was, so I think everything, you have to look at what the context is. Did a blood reaction occur when the anesthesia went wrong? What was it? So I think leadership depends on where you are and what's going on.
Any other? Yep.
Okay. What we're talking about is the complexity of teams in healthcare, I believe. You mentioned on Tuesday, the team looks different than on Wednesday and on Thursday. But we have to give, I'm from the education sector, our learners the toolkit, the communication skills to speak up. And when we talk about teams, we look at those competencies, we have to talk about roles and responsibilities. With any team, there has to be a leader, but who steps up in the leader? I like what you said. It depends on the context, who leads. But then we shift from roles. A leader may be the surgeon, but then if it's the anesthetic problem, then the anesthesia takes over. But we have to equip ourselves to understand that. Aviation, I think, is a little bit easier. Somebody flies from point A to B. Mind you, there's weather problems and everything. There's a pilot and a co-pilot, usually passengers sit in a seat. So they've got it down a little bit better than healthcare because we're so complex. Monday differs than Tuesday, and the players vary every day. What aviation doesn't have right is the luggage piece. So that's a little bit like healthcare. Anyway, that's just my 2 cents.
Listening to this, it makes me think about the purpose for this workshop and the fact that with the composition of teams, the context of teams even functioning on the same unit, but with a different set of patients, and all of the various permutations, makes it that much more critically important that we have a common understanding of professionalism, that we understand and hold each other accountable to that which is, to use today's term, transdisciplinary, and that the leadership role is one of recognizing where the weakness might exist within the composition of the people assembled on this team at this minute, and figuring out how you overcome some of the human frailty that exists within the care delivery systems.
Over here, and then Dr. Shannon.
Hi, I'm a second degree nursing student, so I'm new to healthcare, but I've spent a lot of time thinking about leadership and accountability in previous places I've worked. And one of the pieces that I think is inherent in it, in thinking about it, is consequences. And people have said those words a couple of times, but because I'm new to healthcare, I'm sort of curious how healthcare addresses the consequences of something going wrong and someone taking responsibility for it, kind of what that means and how that process goes and how you learn from it.
Steve Shannon with Colleges of Osteopathic Medicine. To actually follow up a little bit on both the 2 previous comments, it seems to me that the challenge that we face as we try to implement team-based care has to do with the complexity of teams operating coming out of the educational systems that we currently have, which don't necessarily provide a background on how individuals from different professions should operate together, into clinical situations where that's not modeled. And with the backdrop of kind of, at least in the U.S., the legal and liability situation. When you ask where mistakes, you learn tremendous amounts from mistakes. In fact, this is an aside, but when the deans of our schools to get together, they have a session, just of the deans, confidential, which they go in and they share their most memorable mistakes, with each other. It's just a very helpful thing. But nevertheless, so you learn a lot from those. But the reality, the way it plays out, hopefully it plays out in an administrative setting in a hospital, especially if it's in a type of institution where you go through the system and the individuals and you try to figure out what went wrong and what could have prevented it and that type of thing. But then you've got the legal context in which an individual and probably an institution is also being held accountable. And so as soon as, so we can talk about this, but the practitioners, the physicians who are in training and the others will also encounter this world in which they're being encouraged to think about their liability. Whereas, and that sometimes buttresses against the whole concept of trying to select who might be the best, most qualified person to be engaged in making a decision, or to go through a process of giving away, that's not the right term, but diluting one's particular responsibility for an event to the team. So it makes it very complex to do, especially in the current environment that we have.
Of course, then the issues that come up around the competencies of leadership and followership, about communication. We all have our secret handshakes as we talk about culture. We use certain words to mean certain things that supposedly others won't pick up on necessarily right away. And those are all the kinds of things that do become part of it. But as in responding about what are the consequences when something goes wrong, just at the bottom of that, if not just with the team and what might be some morbidity and mortality conference after something happens, but insurance companies, lawyers, hospital administrators are there as well to look at the consequences. And certainly what's going on in the States now with Medicare and readmissions and so on, that can have a very costly impact, if nothing else.
I just want to add one thought as well. Some of my work at the ABIM centers around this idea of teamwork as an individual competency. I don't know if any of you are familiar with that. We've been developing an exercise that really promotes the ability of an individual physician to work effectively within a team. And we have purposely actually avoided leadership within that assessment activity deliberately, so that we could, again, sort of address the fundamental aspects of what it entails to be an effective member of the team, a transdisciplinary team, if you will. And I think what's been kind of striking about that work is that, it's not, and I'm not a physician, but so I shouldn't really be surprised by this, but it's not pervasive. It's the teamness, all of this conversation that we have around teamwork and what an effective team is and the systems approach, to practice. When you are studying it, and I'm a qualitative researcher, so I go in the hospitals and I actually watch teamwork. It's actually fascinating. But when you actually watch it, you realize that it's more often the absence of teamwork that is most striking than as opposed to the presence of teamwork. And I just throw that out there. Our work is ongoing, and we're trying to. That's one of our challenges as an assessment organization, how to assess something that really on the ground is not taking shape in the form that we may have thought that it would look like. So that's just one of my ending thoughts. But I'm cognizant of time. Are there any final thoughts before we move on? We're going to now be talking a little bit more focused. I think we do have one more comment, maybe two more comments, if that's okay, because we do have a few more minutes. And then we'll move forward. Okay.
Hi, my name is Grace. I'm a doctoral student at the University of Pennsylvania School of Nursing. And I think for me, just thinking about the transdisciplinary professionalism and trying to work on a team, I still always have the resounding question of who would be the team leader and how all of that works together. I went to a speech by Dr. Ezekiel Emanuel at the school, who kind of also talked about this this transdisciplinary teamwork, but it kind of seemed like the physician would always be in the role of the team leader in his discussion. And so I think that that's a really big area that we could use a little bit more help with in terms of understanding your role in each space.
Mm-hmm. Yep, agreed. Okay, one last comment.
Thank you. I'm Sue Berry from Northern Ontario School of Medicine. And I guess when I read this case, there's two pieces that are going on in my mind. One is talking about in adverse events, there's the most responsible person. And that, to me, is very different than shared leadership. So the most responsible person, and we know this, can be a good leader or can be a poor leader. But when we talk about shared leadership, it's about the culture and the conditions, the process of how we support each other. And I think that's what we've heard is probably how the team supports each other. If there's been an adverse event, how can we learn from this? How can we be reflective of it so we learn from it, it doesn't happen again? Mm-hmm. It's not whether one person is the blame, it's who's the most responsible person. And it's not about, to me, the team lead, it's the most responsible person.
Mm-hmm. Okay, great. Thanks so much. I think for the sake of time, that's completely up to you. Sure. What do you guys think?
Oh, yeah, this is a good one. Why don't you go back to one? I think that's actually.
Okay. We are now going to move back to case study 1. You're on the admissions committee of a health professional school. A member of the university's board of trustees calls to ask why his daughter was not accepted. The member strongly suggests revisiting her application, which was solid, but just under the acceptance threshold. Discuss pros and cons of accepting her.
Either what is it, a getter or a giver? Yeah.
Yeah, go ahead.
I can make the case study more complicated. In South Africa, we have a responsibility to select students from previously disadvantaged groups. So the students don't only get selected on academic merit. So we get this kind of questions, not necessarily by the Board of Trustees, by parents all the time. So I'm not giving you a solution, I'm just making it more complicated. Because then you have to explain why it's important for this institution actually to accept a social accountability contract by selecting, shall we say, a black student before a white student, which makes it even more complicated. Mm-hmm. But we have to do it. We are morally obliged to do that. And I think if you stay with what your vision of your institution is, then it's the answer. If you start making, oh, okay, maybe this, maybe that, you're just putting yourself on the road to trouble. You have to stick with your selection criteria. Doesn't matter if it's the king and he's going to give you the whole kingdom.
Having been in this situation exactly, I was dean of a osteopathic medical school for 11 years. And the harder one, to some extent, is if it's a strong clinical faculty member's child that's not able to be admitted. Yeah, and from my perspective, you have to trust the process that you have for admission, and you need to stick with it, and you need to do everything possible to prevent biasing it in any way. Your process should be taking into account things like diversity and other kind of priorities. But once you go down this pathway, it's problematic. You might lose your job, but you need to be prepared to lose your job if you're in these type of positions.
This conference is partly about professionalism and transdisciplinarity and so forth. Individuals in professions have got to demonstrate morality and integrity in their everyday behaviors, but we sometimes forget that their institutions also are held to standards like that. And if our institutions do not have open and transparent standards in their selection processes and in their other activities, they lose trust. The professions lose trust. So this is a very key. We're talking about accountability and leadership. This is a very fundamental part, and I also was a dean, and it's a part of the everyday life. And you say we will review the process, and if there are any flaws in the process, we will attempt to remedy them, but there never are, or almost never are, and then you defend the process.
Just revisiting that this, at first I was going to just ask you a question, like how is this related to leadership in transdisciplinary professionalism? But you've pointed the way. I mean, I think that there is also a social contract that professional schools and academic institutions have in terms of this kind of stuff, in terms of the quality standards and upholding those standards, so that when the graduate from Steve's school is on a team with a graduate from someone else's school in a different profession, that there is an understanding that we trust each other in the professions to make these hard choices and hard decisions.
Earlier on, Dr. Jeffries at our table spoke to the contract, what was unique about the contract that an individual professional has with society, or social contract. She mentioned that there are circumstances that we agree to when we become a professional that the common good folks don't agree to. And I think that's what you're speaking to, that there are these moral obligations or duty that we agree to, that when we become health professionals that we have to abide by. My problem is, I don't know how many of you experience, but I don't see that happening. There is a lot of moral shifting around these sorts of things, and especially these kinds of boardroom. Those of you who've been deans, I'm sure you've seen it happening and the pressure that happens around that. But as you were saying, you go into these things, knowing that you might lose your job, right?
I also just want to add, relevant to the trust and each other and whatnot. I think there's an element of the member of the board here as well who has the audacity to call and request such a behavior to be done too. So I just want to throw that out there.
Being a parent.
Over here, and then over here.
Well, I also am in this position as the associate dean who's responsible for admissions, and I agree with everything that's been said. But there's another aspect to this that I would try and bring up for the Board of Trustee or senior clinical faculty, where it's even, I think, more challenging. It's that admitting the student under these circumstances doesn't do her any favors, because this secret will never be kept, and her classmates will always consider that she only got in because of who her father or mother was. So it's better for everybody if she just reapplies next year, assuming that there were no errors in the admissions process.
This is also the kind of decision that is altered when you begin to have the public in favor.
I too have been in a similar position, Associate Dean for Academic Affairs, and get grievance for students' grades or admissions or whatever. I think, and this is about a leadership topic here, you have to be true to yourself as a leader, with the professionalism, the integrity. And I agree with the surgeon. It's about process, so I will investigate the process. But you're right. Pretty typically, it's the process is correct. But I do my due diligence to assess the process. And I think overall, whether it's the parent or a student you're dealing with, you get back with them and you talk. you've recognized the need, you've recognized the question, and I've done my due diligence. And when I get back with them, then you can talk about strategies. What next? They were under the bar, and typically, I think good communication and strong leadership. But as a leader, you have to be comfortable with your decision and hold those values.
So I think this is fairly straightforward. I agree. I sit on our admissions committee. But I also wanted to make the point, something I'm going to say tomorrow, which is I think there's also a role for other disciplines, for us sitting on each other's admissions committees.
Mm-hmm.
And that also can provide multiplicity of good things, including selecting for teamness, but making sure that we hold each other accountable in these transdisciplinary professionalism goals.
You know, one of the things that happens is that we were, Lucinda Main and Carol Aschenbrenner, who's here from, Lucinda's from College of Pharmacy and Carol's from the Association of American Medical Colleges. We're at a meeting of the National Association of Advisors to the Health Professions, talking about interprofessional education and practice. These are advisors to the health professions, so they're the mostly pre-med advisors of the 900 colleges and universities that put students into the health professions. And so in the discussion about how the future is about teamwork and all of these other kinds of things, when they broke up into small groups afterwards with the pre-med advisors, the issue was, okay, now how do we tell our students to write the essay that instead of I'm an independent leader, I know how to lead, I know, and I love when people follow me, to now all of a sudden, how do you tell them to write the essay? I am the most team, a role model for teamwork and team behavior.
I know this was discussed earlier at our table, but having as many of the stakeholders as you can at the table really seems to increase the quality of the decisions that get made, because you have different perspectives about that. So, I think that one of the biggest imbalances we have in our healthcare system now is that we do not have the patient's voice at the table. And without that voice, all of the regulation and, certifications and professional oversight really are way out of balance. And so that was my added opinion. Yes.
I just wanted to make a comment following Dr. Hafferty's discussion this morning. Briefly, he mentioned about conflict of interest policy and linking with professionalism. And so this case for me is looking at a board of trustee member, and I'm going to assume probably signed a conflict of interest sort of oath, and one takes that power and personal gain, and he just violated his conflict of interest with the board. So it totally then tells me that someone doesn't understand conflict of interest in the general society.
Okay, thank you guys for that discussion. We're going to move on. As I said earlier, we've been charged now with populating these slides. So let's think about, can diverse health professionals be held accountable for their collective sorry. Okay. Can diverse health professionals be held accountable? That's okay. You're testing my leadership. My leadership is being tested. I don't think I'm doing very well. Can diverse health professionals be held accountable for their collective actions by patients and society? And if so, how and what factors might come into play? And if not, why? Yeah, go ahead.
So I think ultimately I would like to say yes, but I think before this could happen, patients and society at large would have to be educated, I think a bit more about the healthcare system in which we function, about providers themselves and what they are or are not educated to do or capable of. We're not superhuman, that we can't cure all at all times. We don't always have all of the answers. So I would like to think that ultimately this could happen, but there would have to be a great deal of education and kind of a discussion of actual realities for this to be possible.
I would agree with you. I would say yes. And for me, it looks at the organizational culture, and unless there's a consequence that goes with that collective action, one really has to look at the organization internally.
I would disagree a little bit with how the question is framed, because I think we all operate in situations where there's legislation that defines who is a health professional and who isn't, and those actions by our government are actions by society that hold us accountable. So I think the question is whether there are better mechanisms for health professionals to be held accountable by their patients and society, and in particular how the health professions can act on their obligation to conduct education, research, and care in a way that best meets the needs of society, which links it to Mariki's comments about social accountability earlier.
Richard Murray from Australia. Australia's just been through an interesting process of passing national law so that each state and territory passed reference legislation to a single national law. And so there's now a consistent national registration licensing body and a system of management of complaints that is common across all. And what that's given us, it's still being bedded down, but what it's given us is a common set of, for instance, ethics guidelines, bloodborne virus guidelines, a whole range of things that are now common with common processes across different professional groups. And what's more, whilst there are different individual professional boards, they've all been established with a single administrative infrastructure, which actually takes carriage of cases and policy. And so it came into force in 2010. It's still reasonably new, but it has provided a whole new opportunity, quite apart from professional mobility and consistency and so on. It's provided a whole new opportunity to reduce these siloed relationships and regulation between different professional groups.
This is in line with what you've just said. As I interpret this, we are held accountable, and there's quite an extensive system of accountability now, which is why I like the thing, how can we improve the situation? And I guess we would have to start off by saying we're not totally happy with the accountability system. What Australia is doing is interesting, and the fallout will be interesting. Sweden, for example, has a structured, essentially no-fault system for professional liability, in which the state assumes responsibility, and if people are to accept the state system of reimbursement, they must forego any further stuff in the courts. I sat on a committee in Canada making recommendations to the federal government, and we did suggest something like that, and as you can imagine, it didn't go very far. But right now we're almost limited by the structures that exist, which hold us accountable, and ultimately those structures are the courts. But before you get there, you go through all of our professional organizations who have accountability procedures. Somehow I think the question was more aimed at lower levels of accountability rather than this gross macro stuff. And I think we should, if you're going to get some answers, I think you should go back and tell us a little more the context of what you mean. I mean, do you mean the national system of accountability, systems of accountability that we now have, because you all have a different system in each state, in addition to some national things. And we have different provincial systems.
Yeah. I think that when these cases were put together, was really meant to look at the full range. Yeah. And so not trying to say at the, at the hospital level or at the state level. And, one of the things that you said this morning about how once Canada put in a national health insurance scheme of some kind, that then you had a negotiating table, and you had to bring everybody to there, so. And negotiators, yeah, not just the table. But the negotiators to do that. And I think that's, who knows what will happen in the States in 5 or 6 years as the ACA gets rolled out. But we all know that we're going to hear more comments about death panels and a whole variety of other things where the negotiation doesn't happen necessarily at the negotiating table, but on a much bigger scale.
So when I thought about this question, and again, my training comes into play here, I thought more about cultural and kind of social implications. So the idea of needing to move away from a blaming culture. And, we've heard a few stories about, teams being able to talk about their mistakes and root cause analyses and things like that. So, really supporting a culture where the team can be held accountable if that can actually indeed happen. And then the second thought, from a patient perspective, when I think about myself as a patient, I want to feel like somebody owns my care. So even if there is a team, and I think you alluded to this a little bit, Rich, even if there is a team, I want to feel like if I have a question, if I have a concern or an issue, that there is somebody who is willing to step forward, and manage that for me. So whether that's a conceptual factor or an actual, concrete, actionable kind of thing is to be decided. But those were my thoughts on this. Mm-hmm.
You mentioned, or somebody mentioned the media. I think the media is one way that society will hold us accountable. To work against that or minimize that risk, that we need to have overt mechanisms set up for communication between patients and society and the people who are providing health professional education or health care. So for example, at our medical school, we have an explicit social accountability mandate. We are meant to run everything in order to meet the needs of the people in the geographic area in which we're based, including a large socially marginalized Aboriginal, or what you call American Indian population. So we have an explicit mechanism for representatives of that community to meet regularly and to report directly to our board and our dean.
Mm-hmm. Yep.
I hesitate to bring up the big ugly, but I think if you wanted to cite a case where public accountability in our fragmented system in the United States at both the state and the federal level failed abysmally, we would just cite the case of the pharmacy, aka manufacturer in Massachusetts, and the fungally tainted sterile injections, and the fact that both the state regulatory body and the FDA at the federal level had looked behind the counter or the curtain of that practice, had failed to follow up in an accountable way, and they were still able to inflict enormous harm on the public. And so there certainly is something very broken about our current system of accountability.
Again, as we talked about conflict of interest, one of the issues there was the alleged conflict of interest of the head of the state pharmacy board in Massachusetts and her relationship to the pharmacy that was doing the compound. So, it very often comes back to conflict of interest, and it's not something that in all of this, it's something that's evolving, but I think we still have a long way to go. The issues of conflict of interest around prescribing drugs and relations with drug companies has focused it, but even now we're starting to say, well, maybe we went a little bit too far, and maybe we need to come back a little bit because the rules became too restrictive.
I'm not sure who, if anybody other than the advertising agencies are comfortable with the shift of the pendulum to direct-to-consumer advertising when you use that model for patient engagement.
Are there any final thoughts on that before we move to the next slide? Okay, one more comment.
I'm just going to concur with what you said, where when patients comfortable with teams, think about the future instead of just going and we see a physician or we see a psychiatrist or whatever. In the future, will we have healthcare teams with aging population? Maybe there's a team, there's a nutritionist or dietitian, there's a PharmD, there's a case manager that's a nurse, a physician, so it's a whole team. So the whole notion of individual goes away because we are complex. There's multiple problems. People are aging, and I just look if with healthcare transformation, what would that look like?
Sure.
That fits in with the lifestyle desires of the current generation of medical students.
Yeah.
We're not as far away from maybe being able to go partway down that road because if they're going to have the lifestyle they wish and maintain their professional obligations, they're going to have to reorganize things so that the patients are satisfied.
One follow-up from him and my other comment. I come from a small community in the Midwest, but I help people in the community to navigate hospitalization or when their parents are ill or somebody has breast cancer or whatever. It is unbelievable. I'm a case manager that's just a volunteer nurse in the community. But how people navigate is impossible if you don't have some type of medical background in some of these places.
I think the big area for teamwork is in chronic disease. Look at geriatrics, which is usually the geriatric team and the patients call on which member of the health profession they need for their particular problem, and they know them well enough, and the team knows them well enough. And this is true in diabetes. I ran a diabetes day center for 18 years. And the dietitians and the nurses and the social workers and the podiatrists and so forth all had their own relationships with the patients, as they should. So I think that kind of place is where teamwork really works. I think in the short-term care, it's harder. In acute care, it's because of the team changes and so forth. It's hard for the patient to know who's who and who's in charge.
Mm-hmm. Yeah, please.
I'm somebody who does really well with images. And I was listening recently to a TED broadcast of this man called James Glenblatt, and he's a physicist. And he has, I won't go into it, but the image that he showed was migratory birds. And you know how they move as a unit? Well, what I understand about complexity science or systems science is that there's this term called emergence. And the emergence is, in fact, something that we're able to study now because of our analytics. And this guy, Glenblatt, was studying the economic system using these theories. But I think we're just now beginning to emerge as a society, a U.S. society, to really look at some of these very complex phenomena and take a look at some of the adjustments that we need to do in the infrastructures, in the process, to get the kind of outcomes that we want. I loved hearing what Australia is doing. They're always ahead of us in some ways. Maybe it's because you're so contained, but I don't know. But there is, if we took a look at all that we're talking about, this transdisciplinary professionalism, and looked at it as though we have to find the way to understand the emergence. And that doesn't mean we put a point on the chart. It's that we get that bird migratory movement that is able to then manifest the kind of outcomes that we're doing. And I think that's really where, in my mind, that I can image where we're headed.
I think that's a powerful image. I think in order to apply that science in this situation, we need good data. And part of the data we need is a real clear understanding of the views and expectations of patients and society. And in particular, we often lack that when it comes to socially marginalized people or people who don't have power within our current society. So I spoke about First Nations people earlier. I'll give another example. Clinically, I do addiction medicine. Most of my clinical work is with injection drug users. And I was part of a process with our Public Health Agency of Canada to develop a document that was written mainly by injection drug users entitled Nothing About Us Without Us, as it's rarely the case that when society comes up with solutions for injection drug use, that injection drug users are involved in identifying those solutions.
Well, I'd like to say that's about true, feels true about nursing too. It seems like there's all kinds of people that come up with ideas about what we should do. But it's not what really is real. But thank you for that image. I also am thankful for the Patient Affordable Care Act, because in many ways that law has shifted the focus to high utilizers and the high cost people. And who are they? They're the marginalized, vulnerable populations. So we're going to learn a lot more about that population in years to come.
Okay, we're going to move on. The next slide, it's already up. Can diverse health professionals hold each other accountable for decisions made collaboratively? If so, how and what factors might come into play? And if not, why? Yes.
I think if you take a look at history and ask the question, can non-diverse groups of health professionals hold themselves accountable? It's pretty clear that the guild system operates predominantly. And so I would say that one of the concepts that have come up in this discussion today is that diversity can't just be limited to health professionals, that the other key stakeholders need to be involved in the system of quality assurance and accountability to keep the professionals honest. Because I have a feeling that we would soon adopt each other in somewhat of the same protective manner that we have protected ourselves in some cases. And that's a pretty broad castigating brush, so please don't judge me negatively for that. But I think in general, that's the way history has played itself out.
Good.
I think that we should hold each other accountable, and we should be a part of the decisions about how are we going to do that? What's that process going to be like? Starting from the front end and not waiting until there's a problem and then saying, oh, you did this, you did that, we didn't have this person, we didn't have that. Not going from the reverse, but starting in the beginning with what the parameters should be. And then I think we'll be able to be clearer about those decisions without it being guilt-driven and without it being finger-pointing, but for the purposes of achieving our outcomes.
Mm-hmm. I can share a couple thoughts I had on this as well. Matthew's talk this morning, I was thinking about this a little bit. He was talking a lot about, conflict theory. It's been a while since I've studied that, but things like power dynamics. I imagine it would be difficult to hold someone accountable who was, your superior, and how that would actually play out in practice and how you'd feel about doing something like that, right? So there's an emotional component to this as well. I think there's also a cultural component where there are different, sort of like having the elephant in the room and everyone sees the different part, right? It's like there's different focuses in different professions, and so because of that, people have different priorities and different values and different ways of enacting those values in practice that may be quote unquote right for their profession, but may be quote unquote not right for another profession. So you're going to have conflicting values-based systems there as well. Are there any other thoughts about?
Just as I look around the room, I know that there are some of you who might not remember a television show called Marcus Welby, but Marcus Welby, the all-knowing grandfather general practicing physician who was everything to everybody. One of those things that catches up, sometimes we get caught up with something that's been happening that we really didn't appreciate. And 55% of physicians in the United States are now employees. And Marcus Welby's shingle is gone. That the concept of that local GP probably isn't going to sustain itself for very much longer. But I think one of the things that happens is after the healthcare system gets more into an employment situation, that the employers are going to be able to provide mechanisms for accountability and collaborative practice in a way that maybe we couldn't before. And so starting with the VA, Kaiser and Mayo and obviously many others, and those of you who come from countries that may have a more organized national health system. But I think that this is another way, if it is going to, what factors might come into play, it certainly is around the way that the people interact with each other, either in private practice or in some kind of employed situation.
Yep, go ahead.
I've thought a couple of times today during this discussion, both before lunch and now, that there's an organization here in town called the Citizens Advocacy Center. And it was created, as I understand it, in order to equip public members of regulatory boards to be confident public members. And there's probably a wealth of information in the decades that David Schwanken and his colleagues have been running the center that could really enhance this conversation and this analysis.
Yep, go ahead.
I'm just going to raise the question because we're brainstorming here. In the future, and probably maybe not so near, or probably near, would we have healthcare teams when people come to the hospital or in community settings or clinics? So it's not just they're seeing the physician, but it's a team with a physician, a nurse, a PharmD, all that. And we develop teams that we're very familiar with, so we are going to hold each other accountable, and I'm familiar with. Lucinda's on my team. I'm the case manager on her team. There's a physician, Warren's on her team. And we're taking so many patients on our team. I have a caseload of X number, you do too. And then as patients are discharged, this is in acute care or even in the clinic setting, we had more members of the team that are pre-discharge, are patient teaching, or following up post-care with the Accountable Care Act. The team has to expand because we don't want these patients coming back in. Anyway, I just put that out there for you, where will we develop teams that we're comfortable with and can be efficient and effective and move forward.
Nobody's mentioned this, but it's obvious. If you're going to set up systems for accountability, they have to be systems. They have to be clear, transparent, written, clearly understood, agreed upon by everybody. And I think if you do something like that, the answer is a very strong yes, we can. If you can't develop those systems, if people won't agree, it's going to be much more difficult. And the accountability system you set up for the teams, which will be transdisciplinary, has to fit into the overall, it has to be congruent with the other systems that are in place. And I'll say something which sort of applies to a lot of the things we've been discussing here. I've mentioned it privately. Sylvia and I have spent the last 18 years, the majority of it has been how to teach professionalism or how to encourage the learning of professionalism. And in the last 2 or 3 years, we and a whole bunch of other people have come to think that that was probably not the optimum approach. I think the identity formation movement, which will occur soon, makes us reframe the question. How can you help individuals as they develop their own individual professional identities, which is layered onto the process of identity formation that already takes place. Now, if we transpose that particular objective, and I think within 5 years, most of us who are trying to teach profession, we're already trying to transform our system into one which promotes identity formation. University of Texas has a committee sitting and is going to institute in all 6 Texas schools a major program of identity formation, which is going to cross schools and probably get into other disciplines. They are working on other disciplines at the present time. Then it becomes, I think, much more possible to affect behaviors because you can build in to your program of identity formation, of encouraging identity formation. We can't form identities, only people can. Things that incorporate a team ethos into that identity. It means we're going to have to diminish our emphasis on individual accountability. Lorelei Lingard has sort of written some preliminary stuff on that. So again, I don't think I think we're almost at the point where we're maybe going to be able to take some concrete steps. And of course, the assessment programs that are being worked out are absolutely essential. If we don't, in the educational system, if we don't put in assessment programs, this won't go anywhere. The old educational principle that assessment drives learning seems to be everlasting through the ages.
Are those interdisciplinary teams? The identity formation, is it directed towards interdisciplinary teams, or are they discipline specific?
We are not in a situation to do that yet because we don't have interdisciplinary teams into which we can put people, but I believe that Texas is aiming at that in their, I've seen their documents. Great. And it's really, really interesting. Yeah. And, you know, I think it's where we're going to be in 4 or 5 years.
Nice.
Okay, I'm aware of time, and I actually think that's a great segue into our last slide because you outlined some very concrete, actionable things that we can think about. So to build on that, let's spend the last final moments here talking about what specific and measurable attributes organizations and training programs can exhibit to create and support the preparation of healthcare providers, patients, and communities for transdisciplinary professionalism.
I think it's the point that you made before your previous comment. Without transparency, I think without data, it would be difficult to do that. And so those would be some attributes that the systems would need to have.
So they have to be behaviorally oriented, right? And measurable, and probably at the individual and at the systems level or the organizational level.
Yep, go ahead.
This is not going to be easy to measure, but I think you like that kind of stuff, Elizabeth. Because I think that we really need to think about culture and all that that means. We can put a lot of attention into what needs to happen in our explicit quote-unquote curriculum. But a lot of the teaching and learning happens in the implicit curriculum. And we need to figure out a way to tease that apart.
Yep, go ahead.
I know my earlier comments were summarized as communication on the slides, but I think what I'd suggest is that some systematic, structured mechanism for involvement of patients and society in the design and delivery of healthcare.
I like the point that the woman over there made, and I would also tie in terms of making it sort of measurable, the tool that Dr. Frost talked about, that the culture of the school should reflect the same kind of values that we're talking about in terms of working together and respect and communication and all of those things.
Yep, go ahead.
Richard Murray again. Look, it's interesting that I think there are some drivers that are taking us the other direction. So I think institutional scale, monolithic management structures, a focus on budgets, and metrics, you know, the great and performance indicators, the great non-evidence-based sort of burden upon the system, the distortion of practice to meet budgets and metrics, and then on top of that, the proliferation of increasing numbers of sub-specialties within all of the professions, actually. so that there's a loss of a general generalism and a commitment to the whole person, that people see their own piece. And so receiving medical take is, comes in under the neurologist's bed card, but who try and flick it off to the urologists. And, it's this sort of Samuel Schlemm alive and well, a very nice piece of, a very nice PhD and subsequent work done in Australia demonstrating this very nicely, that intergroup relationships and identity is the single biggest problem for quality and safety for patients, and that it trumps everything. So we can try and put it in explicit curriculum, we can try and bulletproof learners, but ultimately it's the structures that are actually getting worse, that wrap a whole patient care around a patient rather than wrap the patients around multiple fragmented craft groups.
Also, I think along those lines, that this type of practice takes a lot of time, and that is usually expensive. So some way to measure the time spent in order to reach some of these goals, and not have it be considered a waste.
Oh, yep, please, go ahead.
I'm going to say something else that's kind of bold. Education now, we're moving to, what was I going to say? Anyways, it's very public. You can rate your professor. It's out there. TripAdvisor.com, it's out there. Hospitals were reporting near misses. Well, distance education, that's being reported. That's where I was going. We're required to report in the States our retention rates, our enrollment numbers, our career paths. It's all very visible for education. Are we moving toward that with healthcare? Meaning it's going to be very transparent with this, with our healthcare teams. These are getting graded. It's like, it's going to be public knowledge. Who's the best in XYZ? I'm just raising the question. But those, and what metrics would those be? But they would have to be very measurable and transparent, but valid.
Again, we're not as far away as you might think. There are a series of activities going on that we would interpret as trying to measure the informal and hidden curriculum in educational activities. If you look at Hickson's work at Vanderbilt, which assesses the professionalism of faculty members based on patient complaints, Quaintance and Arnold have published a validated form that assesses the professional atmosphere of a teaching environment. It's quite an interesting form. We have a form which is partly published where students assess the professionalism of their faculty member. We have 15,000 individual assessments of 800 faculty members. All of those contain teamwork is on those. But if we're going, we shouldn't be doing this as an individual assessment of interprofessionalism, because frankly, you'll never get it in. If you talk to the professional evaluators, if Eric were here, he would tell you that one of the primary requirements of something is that it be feasible. You can talk about feasibility of a tool. It's got to be incorporated into existing tools because you won't get students or anybody else to fill it out otherwise. So I would be looking to get a relatively small number of landmark behaviors and incorporate it into existing tools, because I think that's doable. And you can break that out into an interprofessionalism category. You need 4 or 5 items, but many of the items that are already in some of these tools actually contribute to interprofessionalism. So you're not as far away as you think in being able to get some metrics.
And some of the things we heard this morning, some of the behaviors and so forth are already there.
Yeah, I mean, our student evaluation of faculty professionalism, hell, half of those things are already on our tool.
a thought that I've been trying to figure out why this keeps resonating with me through several different conversations. It has to do with the recognition, number one. A lot of what we've been talking about has to do with institutional type of healthcare, teams within hospitals, et cetera. And of course, most healthcare takes place in communities. And I think the ability for thinking U.S. focused here, for a primary care system to actually develop requires the professionalism not only with traditional members of the health professions themselves, but with other community members who are caregivers, who are participants in the care of individuals. That's kind of one thought. The other thought is really, I mean, I believe that all of our health profession education institutions and providers have a core ethical need to be focused on the health of the communities in which they exist. And so that needs to be a theme throughout of what professionalism should be for health professional providers. And if you think about a team-based care in a community that is not also encompassing the health of the community itself, that's an easy way to both see interprofessional education and practice, but also to be able to measure, if you will, the interdisciplinary, the team-based care of the team members themselves.
Okay, I think we're out of time. I thank you guys so much for your time. That was awesome. So we have a break. Okay, thank you.